Thank you, Mr. Chairman. I appreciate it very much, and I've been going back and forth as well from CMT, but this is a very important hearing. Mr. Giese, 40 to 45% of my seniors in my district, and I have over 100,000 seniors in the Tampa Bay area. I represent that area, the 12th district, congressional district of Florida, are on Medicare Advantage. 40 to 45%, that's higher than the national average. So they really love their plans, and they love the fact that they have all these choices. I'm concerned with some of the changes that CMS is doing to their risk model. It seems to me that CMS is ignoring or not factoring in certain chronic conditions when determining their risk model. When considering the risk adjustment, CMS seems to ignore or not count patients with certain chronic conditions. Where is the impact of the 2014 changes to the risk model on sick and frail Medicare beneficiaries, in particular to those in the special needs plans area?
Well, changes to the risk model result in reductions in payments to plans, which means more the plans have to react by increasing benefits to everyone, but in particular to the poor and actually sicker people who pay the cost sharing. So these people will have to pay more as a result of changes to the risk adjustment model.
Thank you. Next question is for Dr. Liu. In 2015 advance notice, CMS eliminated the home health assessments as part of the risk model. This is what I understand. As I understand their change, CMS would only count the diagnosis identified in a home visit if and when it was confirmed in a later in-office doctor's visit. Can you explain the dangers of the payment change related to the home-based health assessments, especially for the elderly?
Yes, thank you. As I had mentioned, home visits are part of the continuum of care. And you take out home care and the benefits, it leaves a gap. If you're only going to count a visit or diagnosis obtained at a visit if the patient's followed up in the office, a lot of these patients go to the hospital because of, that's the value of going to the home, early detection, catching something, and as opposed to a 911 phone call and something a lot more serious. The patient can be sent to the hospital for care. So, to only count a diagnosis where the patient has a follow-up visit in the doctor's office, it's very narrow in scope, and it really discounts the advantage and the benefits of a home visit.
Yeah, thank you very much. Mr. Giese, this question is for you. For all these cuts to Medicare Advantage, these plans are dependent on the star ratings to survive. However, it seems to me that special needs plans may be disadvantaged because of their unique population. Can you describe some of the challenges that special needs plans face in the star rating program?
Sure. First of all, it's, a lot of the star ratings are based on survey data, and sometimes it's hard to get to these people. Some of them are homeless. Some of them, they don't know where they live. So it's hard to find them in these surveys. So special needs plans tend to have lower star ratings because we can't find the people, and they don't respond well to the survey as well.
Okay. Now, if the cuts for Dr. Liu and Mr. Giese again, if the proposed cuts occur, what kind of benefits would no longer be provided to seniors, in your opinion? Example of some of the benefits that they might lose if the cuts take place.
Well, from our delivery side, I think you're going to jeopardize all of the extra home visits, perhaps. I mean, that would be one example. I mean, we have a lot of programs built around, again, the continuum of care, visits from pharmacists and social workers, which have sufficient costs. And, if we're on a budget and our revenue is reduced, that's obviously going to jeopardize a lot of our programs.
Remember that cuts in benefits are not just additional benefits over Part A and B. They're also changes in cost sharing. So if the plan has to increase their cost sharing, that is a reduction in benefits.